Alright, so I don't know where I left off on the last video. I ran out of time. My camera only records for 20 minutes for some reason, so I'm just going to mention there at the last time that vitamin K, we can overcome the effects of warfarin with sufficient amounts of vitamin K. If we have enough vitamin K in our system, like we give it intravenously a lot for like hemorrhagic strokes, we can overcome the effects of it, and then the liver can make factor 7. So that's the main one that it affects in the blood. There's actually a couple different ones. It also affects factor 9, factor 10, and 2. You don't need to know those as much for testing purposes, but the one you got to know is that warfarin affects the extrinsic pathway, which is measured by the prothrombin time test, and it's going to be influenced by the amount of vitamin K that is going to be made unavailable by warfarin to make factor 7 in the liver. Okay. All right. All right. So hemostasis and thrombosis. So hemostasis and thrombosis kind of go hand in hand with the clotting cascade. So hemostasis, the way we get to hemostasis is exactly this. We form a clot or form a thrombus. It's also the basis of activated partial prothrombin time and prothrombin time. It's our time that we need to make a thrombus. But this can also go awry and become pathological if we are forming thrombuses and stopping or clotting our blood at inappropriate times or inappropriate areas in the body. So he gave a couple really good examples of this. So the first one was disseminated intravascular coagulation. So this is influenced basically by a lot of different things. So let's see, what do I want to talk about here? So there's a lot of different kind of pathologies or diseases that can cause this. Endotoxins can cause it, a lot of different things. But what's going to happen in this pathology is that your body is going to coagulate or make a bunch of small clots, and they're going to plug up a lot of your capillaries. And they're going to use up the amount of available clotting factors you have in your system. So you're going to make a ton of little clots in disseminated intravascular coagulation, and you're going to get to the point where all those little clots are building up in the tissues, and some of the tissues where they build up are going to be starved for blood flow and for oxygen, so they're going to become hypoxic, and that's bad, obviously, especially to our more vital tissues we have. And then since that all those little clots are using up all of our different clotting cascade factors, we're not going to have enough to be able to form a clot when it's appropriate. So one of the risks of disseminated intravascular coagulation is that all these factors will be used up after a certain amount of time, pretty long amount of time, but a certain amount of time, and will actually become, anytime we have a certain amount of injury, it'll bleed profusely because we'll be out of clotting factors. So we're going to basically bleed out inside of ourselves. All right, so we've also got some platelet, I'd also like to point out that in DIC, or disseminated intravascular coagulation, there's a test called the D-dimer. It also is used to diagnose DVT, or deep venous thrombosis, and pulmonary embolisms. D-dimer is just a test of how much plasmin insoluble cross-linked fibrin we have. So it's a measure of how much clotting we have. So it's a measure of how much fibrin is connected to platelets to make like a plug and an insoluble clot. All right, so it's going to be elevated in DIC. Remember that. We've got some hemorrhagic disorders. We got thromboembolic thrombotic cytopenia purpurea and idiopathic thrombocytopenic purpurea. Both of those are going to be characterized by purpura, which are like somewhere in between petechiae and ecchymosis in appearance. And ecchymosis is just a big old bruise. I don't know why he didn't call it that, because in the ER, I always hear them call out when they're doing like a trauma exam. We got significant ecchymosis on their dorsal aspect of their back or whatever, I don't know. And I always wondered what that meant, and I asked somebody one time, and they're like, well, it's just bruising. That's it. I'm like, oh, okay. So ecchymosis, big bruise. And then petechiae are little pinpoint hemorrhages. They don't blanch. And then purpura are kind of going to be in the middle. So they're not going to be quite a big bruise, but they're not going to be these little tiny red dots either on the skin. They're going to be a little bit bigger, and they're going to be basically also kind of the same thing as petechiae, except they're going to be significantly larger in appearance. And they're both caused by, or the thrombotic thrombocytopenic purpurea is caused by antibodies that don't allow the platelets to stick together. So you're going to get bleeding because you can't form a platelet plug, and you're going to have those purpura spots all over your skin. Von Willebrand's disease, hemophilia A versus hemophilia B. Hemophilia B is factor 9. Hemophilia A is factor 8. Hemophilia A only manifests itself in males. Hemorrhagic, let's see, von Willebrand is a deficiency in von Willebrand's factor, so it's the factor that binds a platelet to the tissues. If you don't have it, you're going to bleed out. This is more of kind of our hemorrhage stuff. And then we got kind of the stuff that I care about more than this crap, which is our thrombosis and hemostasis. So if we have hemostasis and thrombosis when we have an injury, that's good, because it's going to seal off our vessels and allow us to stay alive. But sometimes it can happen at inappropriate times, and it's not such a good thing. It's actually a severe risk or a problem. So the really good way or good example that he gave of this was thrombosis in your deep veins, and also like thrombosis in here. Let me see what he has. Thrombosis that are formed by your abdominal, like your aneurysms or your AAAs. So you can have arterial thromboses, or you can have venous thromboses. These are caused by just sheer stress on the vessel walls. That's why hypertension is such a risk factor for DVT and stuff like that. You're going to get a clot formation on the vessel wall. The clot breaks off, and then it becomes a thrombi. Thrombi can go ahead and travel, making it a thrombus. And when it travels, it can become lodged somewhere in that you don't really want it to lodge. Like, for example, you can have a pulmonary embolus. So a pulmonary embolus is just a thrombus that has traveled, making it an embolus. Thrombus is attached, embolus is unattached. Embolus is moving, excuse me. A pulmonary embolus, which usually starts out as a DVT or somewhere in the legs, and is carried into the lungs by the vasculature and lodges itself in one of the smaller arteries within the lungs. So that kind of starves one of our portion of our lungs that is supplied by that artery of blood flow, and you get a VQ mismatch, so a ventilation perfusion mismatch. It's going to be well ventilated but poorly perfused because of that occluding embolus. Deep venous thrombosis, they're more common than a outermost venous thrombosis. So a lot of your veins travel superficially in your legs, but there's a couple deep ones like the great saphenous and stuff like that, femoral vein, stuff like that too, that are going to, since blood flow is a lot slower in them, you're going to be able to form a clot in those vessels much more easily than you would an artery. And when it stays there, when it stays put, you've got a thrombus. And thrombuses don't move, and when they stay put, it can keep building up and creating a bigger and bigger and bigger clot until it occludes the vessel. And this is usually really painful when it happens. Sometimes, or like I think it's 50% of the time that it's not symptomatic, but with a DVT, you're usually going to have some sort of pain. It's going to be tough to walk on it. Big risk factors are estrogen. Taking high levels of estrogen can cause it. Or they can break off and become an embolus and move somewhere else to wreak havoc. Paradoxal embolisms are embolisms that come from the venous circulation and somehow, or through the shunt or an atrioventricular defect, like we're learning about in anatomy right now, they can travel through that shunt and get to the arterial systemic blood flow easier and become lodged somewhere that they shouldn't be. So these are relatively uncommon, but they often end up in either the coronary arteries to create an MI, or the one of the cerebral arteries, which you could take your pick there, and they cause a stroke, an ischemic stroke. Okay. Pulmonary thromboembolism, like I said, I talked about that. He also talked about a saddle embolism. So saddle PEs are created where the pulmonary artery bifurcates in the lungs, and it just sits in there, and it's going to eventually close off both primary branches of the pulmonary arteries, and it's going to starve that entire lung of perfusion, and those are really bad, like really bad. You've got to give TPA for that. That's all I know about it. So you've also got fat embolisms, which don't happen very often. That's just where fat breaks off. Or they are actually common, but they're asymptomatic. You don't really get them. They're caused by fractures of long bones and tissue trauma, burns. And then you've got air embolisms. So actually, I'm sure everybody in here during their time of working in the healthcare field has heard, don't put a bunch of don't allow a big air bubble to go through an IV line because that's bad. Well, it takes about 100 cc's of air to actually cause any kind of trouble in the vasculature from an air embolism, so it's not a huge risk. You can also have amniotic ones where some of the amniotic fluid from a pregnant mother leaks out into one of the vessels by like a vessel rupture or something like that, and it's really bad if it does that. It can be fatal, up to 20 or 40% of the time. And then the last thing you talked about was shock. So I like shock. I think it's cool. So there's shock is just basically characterized by hypotension, inability to perfuse the tissues, and cellular hypoxia. So bing, bang, boom, you got them. They're right in a row. They all lead to each other. It's just like a big, long chain reaction that causes death. It's not a good outcome. So we really watch out for it. The major classifications of shock, so you can have cardiogenic shock, you can have hypovolemic shock, and then you can also have septic shock. So cardiogenic shock is going to be caused by some kind of cardiac origin that is going to not allow you to perfuse the tissues. So it's not allow you to pump blood. So a good example of this would be a heart attack, an arrhythmia, especially a fatal arrhythmia, like a ventricular fibrillation. Anything coming from the ventricles is pretty bad for shock. Or an infarction. A pulmonary embolism would also be considered a cardiogenic shock because it's going to cause right heart strain and not allow the heart to pump blood like it normally would through the lungs and perfuse the tissues that way. And then also the last one, let's see what he has here. Oh, cardiac tamponade. So cardiac tamponade is when the pericardial space becomes filled with blood or fluid, and as there's only so much space in the pericardium, and when your heart contracts and then tries to fill back up, that fluid or blood takes up some of the space where it normally would expand, and it can't expand that far. So then you get reduced filling of your ventricles and reduced perfusion of the tissues. Hypovolemic shock, that's caused by any kind of trauma, or that's just basically a low blood volume causes that kind of shock. So any kind of penetrating injury where you're bleeding out into the open. You could also be bleeding rectally. So any kind of thing that is going to cause you to lose blood is a hypovolemic, or can lead to hypovolemic shock. Also burns and fluid loss, so if you're dehydrated. And then septic shock, which is kind of my favorite one. So septicemia, so bacteria in the blood. The systemic blood infection, and then you've got your endotoxic shock. So an example of a septic shock of endotoxic origin would be, oh, it's on the tip of my tongue now, from tampons, toxic shock syndrome, where bacteria releases an endotoxin, which we learned stimulates a huge immune response and massive inflammatory reactions that allow a lot of your fluid to leak out of your vessels and you to go into shock. Then you can also have neurogenic shock, which is mainly caused by strokes. So you get loss in vascular tone and you get peripheral pooling of blood. So anytime that you get a ischemic or pressure on a certain part of the brain that is responsible for maintaining vascular tone, you're going to let those vessels dilate and thus let the blood pool and not perfuse the rest of the tissues. And then anaphylactic shock, I feel like that one's self-explanatory. We talked about that so much now. Multi-organ failure can lead, or shock can lead to multi-organ failure. They talk about the empiric criteria for diagnosis of shock. You gotta have like 4 out of these 6. You should go through that, just so you know. And then the stages of shock are, I think, important. So you can have non-progressive stage, the progressive stage, or the irreversible stage. So irreversible means you're gonna die from the shock. The non-progressive stage basically means that you're compensating. So the shock, or your like pathology, whatever is causing you to go into shock, is being well compensated for by your body's normal mechanisms. So like for instance, if you have a hypovolemic shock, like where you got stabbed and now one of you nicked an artery and you're losing a lot of blood, your blood vessels would go ahead and they would try to vasoconstrict everything in your periphery. So we're going to keep only blood to our vital organs. Since we only have a limited amount of blood now, we're going to keep it to our vital organs. We're not going to perfuse the peripheral tissues, which are much less susceptible to hypoxia than our visceral tissues are. So that's a way we can get around it, and it's going to keep our blood pressure constant in our at least our visceral organs for a little while. But then at a certain point, you're going to get to you're going to lose so much blood where your actually body